in this country. And
It's ridiculous.
excuse me?
It's ridiculous.
It is ridiculous. Yeah, it is. But it just kind of shows you the bias against interventions in psychiatry and modern treatment. But it reflects the mindset too that unfortunately psychiatrists have somehow become conditioned to think that the only effective treatments are newly patented, rather expensive pharmaceutical agents that just go on the market. And that's just not the case. But ketamine works on many different levels. And another thing that this is a vision I had during my ketamine session was a peninsula covered with lights that were, the nodes were kind of interconnected. And about 10 months later, I realized that it was the peninsula of Florida where I was, because in Tampa, I didn't realize it at the time. And I had done a lot of thinking about how difficult it was to promote and disseminate these treatments, and the nature of suffering and so forth, and going into it. And the thought that I had was that each node of this network represented the human life of someone that was currently living or had lived, and the connections between the lights reflected the necessity that we have of connecting with each other to bear the pain that is a part of every human life. And it's still a lesson that I carry with me. So I think that as much as we get benefit on a pharmacological level and many other levels, that there is a kind of a spiritual component of recovery that we can get if we take advantage of with psychedelics that has to do with accessing a state of mind that is described in basically all modern religious traditions as an outcome of meditation, or Sufis do dancing or what have you. And this is the sense of connectedness, that we're all one. Mm-hmm. And I think the ego-dissolving state. I went back to a conference that Dr. Culp had with some of the interpersonal, transpersonal psychologists, and we had quite a discussion on whether or not the state was the same as described in various religious traditions and psychedelic drugs, and there was an interesting discussion about that. But one of the people that attended the conference was someone who had a lifelong history of OCD and depression, and had been able to get into the ego-dissolving state just with very intense meditation. And this lifelong illness he had went away for 9 months, and then when it came back, it was not as severe. So that
I've had that too.
pardon?
I've had that too.
You've had that too with meditation?
Yeah.
Yeah. Did it help? Yeah. So, treatment dissemination. I'm going to come back to this. Why does an effective treatment go extinct to be replaced by less effective treatments? Do effective treatments sometimes fail to get adopted? Early on I thought there was a good chance that ketamine would not get out there, and I still think that there's a possibility that it may not become widely available, or that it will become available in such a contorted way that people will not be able to use it effectively. And I think that's something we have to watch out for. And why would we in medicine fail to use all effective treatments, particularly if they're not better options? And because this is not a problem with just psychiatry, that in all areas of medicine there are treatments that could be used but are not used. One example I heard about was when a child is born premature, they have respiratory distress syndrome. Their lungs are not fully developed. And the best treatment for this was, I think, nitric oxide. And the only source of nitric oxide were welding supply stores. Okay, so that, but pediatricians and ICU doctors, you could just imagine, having to talk to some, plaintiff's attorney about why in the hell did you take this tank of welding gas and have the infant inhale it. And so it finally took somebody buying up all the suppliers of nitrous oxide, nitric oxide, and labeling them as medical gases and selling them back at a considerably elevated price. Another example of this, I think, is fecal transplants for C. difficile. That there are some treatments that just, for a variety of reasons, just don't get out there. Okay. So, facilitated psychotherapy. And here I'm going to talk a little bit about ketamine as a plasticogen, because I've come to think of ketamine as being kind of a universal solvent for psychotherapy, something that can facilitate the type of learning and the changes in the brain that we hope to occur with effective psychotherapy. One of the things that's interesting about psychotherapy at this stage is that we are beginning to understand it in terms of the brain systems that we interact with and hope to change with learning. And so we're beginning to understand not only what medicines might be helpful, but what psychological techniques might be helpful. For example, the involvement of the amygdala in emotional conditioning is a component of post-traumatic stress disorder is a very important part of this. Okay, here's case number 2. This is someone I saw in 2007. This is a 38-year-old nurse who had unipolar depression, severe post-traumatic stress disorder from severe traumatic abuse and a large dysfunctional family growing up, and severe back pain from an automobile accident. He was wearing a back brace, and he was on about 90 milligrams a day of methadone. And we did IV ketamine to treat the pain, and it treated the depression, and surprisingly got rid of the daily flashbacks and nightmares that he was having from his post-traumatic stress disorder, and allowed him to taper off all of the opiates and get out of the back brace. Okay? And when we provided the ketamine at a 2 to 3 week interval, it controlled his PTSD and depressive symptoms and pain. Okay, and so it was just a very good treatment for that. And this is typical of many of the patients that we see that have this combination of depression, post-traumatic stress disorder, chronic pain, that they do better with this. So far, the data concerning ketamine for post-traumatic stress disorder is rather limited. Federer 2014 demonstrated benefit for PTSD in a study of 41 patients assigned to ketamine or midazolam being kind of an active comparator that will produce an altered state. Ketamine produces a period of decreased anxiety to trauma triggers. And so I think it's most effective when you combine this with an exposure-based psychotherapy like EMDR or prolonged exposure therapy, that has something that has proven benefit for PTSD, and it will enhance the ability to take advantage of the exposure-based psychotherapy. For example, one of my patients had trauma associated with exposure anytime she was in the presence of a rodent, because her initial trauma involved her assailants capturing rats and using them to bite her. And following ketamine, the day following ketamine, she was able to go into a pet store and pick up and handle rats, which she'd never been able to do in her life before, and self-expose and get past this particular trauma cue or trauma trigger. But I've really come to think of 2 poles of symptoms with post-traumatic stress disorder, one being a pole associated with the amygdala, the emotional conditioning component, which we know most about fear, but other emotions are probably part of this here too: guilt, shame, anger, and so forth. We know less about that and about how to alter that with effective psychotherapy. But then the attachment system, okay, is another component of it, because, and this is an area I didn't really know anything much about until about 4 or 5 years ago. I began to read about it and educate myself about it. I think it's a very important part of the ketamine effect. But probably many of you know about this story that it begins with a gentleman named John Bowlby, who was a psychoanalyst in London in the 60s, who was seeing a lot of people who had been separated from loved ones during World War II, and he was treating them for depression and anxiety, and he became interested in the role of the separation during childhood upon the adult symptoms of anxiety and depression. And his college roommate was this guy, Harry Harlow, that probably everybody has seen a picture of these little rhesus monkeys in a cage with a wire mother and a cloth mother. Harlow had studied bonding behavior in rhesus monkeys, and so Bowlby's work was informed by this animal literature on what sometimes is called imprinting behavior. He teamed up with a woman named Mary Ainsworth, who was a single mother that had an interest in this topic and had studied it, I think, in New Guinea, and I believe she was his graduate student. And they did something called the infant strange situation, where they would take a mother in a room with a 2 or 3 year old child, and a stranger would come in the room, and the mother would leave the room for 5 minutes and come back, and they just simply recorded what did the child do during the period of separation and reunion from the mother. And surprisingly, they could identify 3 patterns of behavior that were reproducible, and that if they looked 6 weeks later, they saw the same pattern of behavior. 2/3 of the time, the children had what was called secure attachment, which is pretty much what it sounds like, that when the mother left the room, the child would fuss, but kind of settle down. The stranger was friendly, there were toys in the room, would reach out for the mother when she came back in, and get picked up and rapidly soothed. Could be the father, his primary caregiver. There was just kind of nonverbal communication that was obviously healthy. The other 1/3 of the time, the children had what was called insecure attachment, and it took one of 2 forms. One form was called hyperactivating attachment, and in this form, the child became very upset and distraught and fussed and cried during the entire period of separation from the mother, became even more emotionally aroused when she came back in the room, and maybe had some anger, and took quite a while to settle down. And the other type of insecure attachment was the opposite. It was called deactivating attachment. And in this situation, the child seemed not to notice when the mother left the room, would actually turn around, crawl away, and resist being picked up when she came back. But if you measured cortisol and stress hormone levels, they were elevated. The child was obviously stressed. And so Bowlby and Ainsworth reasoned that we have evolved an attachment system in our brain, like we have a system for vision, a system for hearing, and so forth. And the function of this with us, as it is with the rhesus monkeys, is to forge and maintain a bond with a caregiver when we're young. Of course, the reason we have this is we're going to starve to death if we can't solve this first most basic task. And that in the best of circumstances, we can have secure attachment. Sometimes through a difference in genes, environment, we learn that we have to overactivate the attachment system, and we get more of the emotional pain and the behaviors like crying and so forth that help to securely get help when perhaps from a caregiver that's slowly or intermittently responsive. And other times, some babies are just uncomfortable being held, or maybe it's less stressful to just shut off the attachment system than to cry and cry and cry and not get help. And you end up with the deactivating form of attachment. Okay? And surprisingly, when they followed these children up 20 years later in the 60s, they were in their early 20s, they could find a good correlation between the patterns of attachment behavior they had as children and what they showed as adults. That people that had the hyperactivating attachment pattern as children tended to have a lot of abandonment fears, a lot of anxious focus upon relationships, a lot of problems with anxiety in relationships, and those that had the deactivating pattern were people that were uncomfortable with emotional closeness and tended to push people away. And of course, as luck would have it, sometimes these two patterns of behavior get together in a couple, and this is what the marital therapists talk about. So the developmental psychology component sort of converged upon the study of attachment behavior in intimate relationships, and it seemed that the templates that we form as children are adapted later on for adult relationships. Now, broader than that, I think, are the attachment templates that we have with people in general. You know, some people are curmudgeons. They don't trust anybody. Nobody's any good. You know, they tend to keep themselves separate. You know, and of course the attachment schema has an outward-looking component. You know, what do you expect of other people? And an inward-looking component. What do you expect of yourself? And they're not written in stone. They can be changed, and probably changing the attachment schema is a large part of the so-called non-specific effect of psychotherapy. As we become more secure in a therapy setting, we become more able to be secure with people elsewhere. But anyway, I got interested in this because I had about 5 patients that had 5 or 6 patients. I now have a few more that would always have a very robust, strikingly robust effect with ketamine.
Thank you.
Came in and had a session and did not have any effect at all. And this occurred in situations where there was some issue involving attachment trauma that came up. That one patient had been brought to a treatment by a female caregiver that was their only female friend, basically. And this female friend had been accepted to a nursing program out of state, and that was the last time that she was going to go in for treatment. Another patient had learned from his wife that she was intending to file for divorce. Another patient I engaged in a discussion with the father that traumatized her as she was coming out of ketamine, and she did not have an effect, and so forth. So this is kind of what got me interested in attachment and ketamine. Another thing is that I've got a website or an email group of people that are doing ketamine throughout the country, and I was corresponding with David Feifel in San Diego, who did 3 patients, not a single one of them responded. And there's a guy named Luis Jufra in St. Louis, WashU, that did 10 patients, not a single one of them responded. And trying to figure out, you know, what's the difference here? You know, how is how are things different? The only thing I could come up with was the mental state, the setting, that the protocols that we tend to write about how to do things in the hospital involve lots of chrome and a bunch of strangers standing around you looking at you dressed up like a Christmas turkey, and not the best setting to take a psychedelic drug in. This is something that the earlier psychedelic investigators found that somehow doing LSD on a nice sunny day with friends differs from doing it in a small room surrounded by hospital security.
Do you know if there were actually any adverse reactions to those 13 or 10?
I don't know that they discussed that. I think that probably I rarely see what's called the emergence reaction with ketamine. That they say that 12 to 14% of people that are anesthetized with ketamine would get severe anxiety and terror coming out of it. I don't very often see that. But I think if you're in a busy emergency room and it's loud and noisy and people are running around, not really connecting with you mind to mind, not mentalizing with you, then.
But it is a natural blowback effect to anything that suppresses the central nervous system, or it has that effect on the body. It is a natural response that's triggered in some individuals that are highly traumatized.
That's true.
To have an anxiety response to any depression of the nervous system, because there's such a fight or flight response going on continually with that person with high anxiety. Surprisingly,
though, I've treated some very, very, very severe patients with PTSD, and I've only rarely had it actually produce flashbacks and nightmares during a session. That if you're careful and you make the patient feel safe and you incrementally dose them, it usually does not happen. Actually, it will relieve the PTSD.
Just to follow on, if there weren't adverse reactions, 10 out of 10 is really significant.
Yeah, I would think so, yeah.
So, you need an explanation.
Yeah.
It seems like that would be helpful to get an explanation for it.
Yeah. Well, and
It's
throughout,
not sad.
yeah,
Just said it's
the pain patients I treat, talk about, they go to some clinical settings and they really feel like they're being listened to and they feel safe and secure. And it's very different going to somebody else that is hurried, that's so focused upon the procedure that they don't mentalize with you, they don't connect with you mind to mind. But it's much more of a traumatizing experience like that. And so kind of makes me interested in this whole things. Okay. So basically, treating PTSD involves not only getting rid of the nightmares and flashbacks and the hypervigilance, which generally responds pretty quickly to ketamine, and then if you combine it with psychotherapy, it gets better, but also trying to work with and mold the attachment schemas over time. And that's something that we know a lot less about. There's some very interesting brain imaging research, like Pascal Verteca, showing structures that are involved in the insecure forms of attachment that get activated. So that I think probably the next 10 years we'll see this come into its own as an area of inquiry. This is a study that was done at Yale showing that under chronic stress, the spines on spiny neurons tend to retract. This is in the control group up there, the little knobs or spines on spiny neurons. It's thought that maybe this helps to prevent damage to the nerve cell when you get the glutamate overdrive that occurs with chronic stress. And ketamine, through its actions upon a protein called mTOR, cause these spines to come out. So basically the brain rewires itself so that ketamine, this is I think some reason why we might think that ketamine enhances the ability of the brain to change. So we've evolved this technique, which I initially evolved years ago when I was treating people with sevoflurane and electroconvulsive therapy. The main focus of a session being creating a sense of safety, what Bowlby called a secure base. Talking about this as a journey of learning and understanding is helpful because often people do encounter important things involving their own life journey, really, under ketamine. And we start with a 0.5 milligram per kilo, which I give in 2 or 3 separate ion injections. The ion injection produces a peak effect. Usually, you set your clock by about 20 minutes, you get the peak effect, and by an hour, patients are much better. Usually 90 minutes after injection, they're ready to go home. Let's see. So this is what Bowlby talked about, that our caregiver serves as kind of a secure base, and that when we're young, we explore the world, and we get separate from our caregiver, and it produces anxiety, and we seek proximity, and we go back and again kind of recharge our batteries with a secure base. So that ketamine, we try to do a secure base experience. and actually do see attachment schemas coming out during treatment. Patients, I remember treating a lady that had a hyperactivating attachment schema and began under ketamine to say, I'm taking up too much of your time, I should leave, I feel embarrassed, I feel ashamed, just like she had experienced growing up when her emotional needs were not being met around a large family sheet. And this is this is another way of looking at attachment style. One involves the internal part of the attachment style is looking at your model of self. So if you're secure, you have a generally positive view of yourself that you can cope with stress. If you're insecure, you tend to have a negative view of yourself. Preoccupied is hyperactivating, is the other term for that. And then a model of other, again, positive would be a secure perspective on others. A negative would be dismissing as a deactivating style. This would be a tendency to think that others are not helpful to you, that there's no help elsewhere, and then you can cope with anything that comes up. And then the fearful is the fourth category that was added in later on by Mary Main and others. It was called disorganized. And these are people that have an approach avoidance conflict, that have an extreme need for intimacy and closeness, but at the same time an extreme fear and anxiety of intimacy and closeness. And this generally occurs in a setting where you're forced to rely upon a caregiver that is physically abusive to you. So combining psychotherapy and ketamine, we strongly recommend doing individual psychotherapy, either provided in the office or in collaboration with the patient's therapist. Sometimes the therapist comes in. Because I'm so busy doing ketamine, I usually try to do this as a teaming up with the therapist that does psychotherapy day in and day out, and that knows the patient pretty well. And then we provided group therapy, focusing upon schemas and automatic reactions, mindfulness skills, and then talking about attachment and something called compassion-focused cognitive behavior therapy that a guy named Paul Gilbert developed, kind of working on trying to explicitly understand and remodel the attachment schemas that people present with, and then understanding and revising the life narrative and meaning. Okay, getting into pain. Pain and PTSD and depression and addiction go together. Okay, this is a patient I saw in Cottage, 89-year-old woman who had depression and had diverticulosis, where she had outpouching of her colon, producing abdominal pain, was on opiates for this, which had the adverse effect of slowing down bowel motility and making the abdominal pain worse, and she just wanted to die. Didn't want to do anything at that point. And we couldn't taper her off the opiates because of abdominal pain, and actually tapering off of opiates tends to produce increased bowel motility, which would make things worse. And the ileus reduced bowel motility worse than the diverticulitis. We did 4 ketamine sessions, and this allowed us to rapidly taper the opiates. She was on fentanyl, get her down to a level without withdrawal symptoms, that we could switch her over to Suboxone, which is a partial opiate agonist, and improved her depression and got her well enough to control her pain and get her out of the hospital. So there are many psychological aspects of chronic pain. It's frequently associated with depression and PTSD and anxiety, and recently there's been growing literature on attachment trauma and insecure attachment and pain, and particularly chronic pain chronification, that's what they call it. And we have actually 2 pain systems in our brain. We have a lateral pain system in the somatosensory cortex that codes the intensity of the painful stimuli, and then we have a medial pain system in the dorsal anterior cingulate that is associated with the emotional catastrophic component of pain and the suffering of pain. And I've got a slide about that later. Other psychiatric disorders such as OCD and ADD interact with the pain and give problems with addiction or amplification of pain. This is a slide from, it's not a very good slide, but it's from a brain imaging study where you put your hand in a hot container of water, and the hotter the water, the more you get activation in the lateral somatosensory cortex in the upper part. Okay, and then the medial pain system is more involved with the psychological reaction to pain. Ketamine has most literature in something called complex regional pain syndrome, or RSD, that's a very severely disabling condition where the sympathetic innervation of a part of the body is damaged, and there's something called allodynia, that the non-pain systems begin to transmit pain signals, and this is a process that involves the NMDA receptor, similar to long-term potentiation as a learning phenomenon. Ketamine reverses this. Also is helpful with phantom limb pain. Phantom limb pain is a good example of a pain schema, that when we lose a limb, very often we get this severe type of pain, and it may involve having a sense that the absent limb is contorted in space or twisted behind our back or something like that. It's very difficult to treat, and ketamine is helpful there, but Dr. Ramachandran in UCSD has actually found a way to treat this using a mirror box, which is interesting, that you put the absent limb in a box that has a mirror on it, and then you do physical therapy movements with the intact limb, and you get this visual feedback that you're actually moving the limb that's no longer there. And somehow or another, this undoes the pain very often, and treats this very severe type of pain. Visceral pain is also useful for fibromyalgia. I've seen some extremely severe cases of chronic daily headache that responded very well to ketamine. IM and intranasal ketamine, like the triptans will abort headache, and I've seen people that have 20 years or more of severe remitting chronic daily headache that's done well with ketamine. In complex regional pain syndrome, one of the people that I visited with when I visited with Dr. Culp was a guy named Anthony Kirkpatrick, who was the head of the RSD Foundation in Tampa, and he had set up a protocol to look at something called ketamine coma therapy that involves putting people with RSD to sleep for a period of a few days. The idea is that you totally damp down the pain signals. And we're talking about a condition that is severely disabling, extremely painful, one of the worst conditions that you can have. And there's some evidence of Germany that this is helpful. He wrote a protocol to do it, was not allowed to do it in this country, and it's available in the University of Tübingen in Germany, and then he's got a group in Monterey that does it, but at a considerable cost. So although the use of ketamine for pain is even much more well documented for depression, it's still not widely covered by insurance. And so I see a lot of patients that can't afford the rate that anesthesiologists would charge, and I can provide it to them because I bill for an hour of psychotherapy, and they can afford it. Okay, so now we're going to get into dissemination, okay? And we're going to talk about two types of systems, okay? And the system that we are most familiar with thinking about scientifically is a mechanical system, okay? Like a clock. It's a linear dynamical system, and basically science runs on mechanical models because it's predictive. You know, if we encounter the more messy, what's called a complex adaptive system, represented here by a cat, we very often will try to produce a linear model to make it a predictable model that we can control and we're more comfortable with. And this is, I think, a reason of why we are missing these treatments, is because we expect medicine to operate like a mechanical system, like the algorithms that we see in textbooks, and we expect everything to work with clock-like precision and the best treatments to come to the front. And it's not a mechanical system, it's a complex adaptive system. So, from a mechanical view, treatments are like scientific facts that are replaced by better treatments as they become available. Valuable treatments will always be adopted. This is the misconception that people have. But the actual nature of treatment evolution is survival of the fittest, but not best treatments. That healthcare is like an evolving complex adaptive system. That better treatments are sometimes replaced by inferior treatments or not selected at all. Just like in an ecosystem, sometimes we like to have the condor, but the mice and other things drive it into extinction, you know. And pharmaceutical companies and insurance companies largely control selection because the financial incentives for providing a treatment are considerable. And also the legal profession limits what can be done. And this is probably why it's virtually impossible to do ketamine research and make it available. The VA does not have ketamine as useful as it would be for pain, PTSD, depression, all the problems that they see. So treatments are like memes. If everybody familiar with the term memes, probably we know this from a computer, but memes are, this is a term that Richard Dawkins introduced to refer to pieces of information that act like genes and that are good at getting replicated and spread. So they take part in the Darwinian algorithm of variation, selection, and replication with preservation of form. So in the upper left-hand corner is someone that's been cannibalized by a religious meme that has co-opted their resources and put them to the use of spreading the religious meme. This sign on the right used to be on the back of every car, and you still see it occasionally. It's like the memes that are on your computer virus. And unfortunately, some memes don't replicate very well. In the bottom part of the screen here, we have a multidisciplinary pain team. This is what we know is the best way to treat pain, where we have anesthesiologists, neurologists, neurosurgeons, psychologists, and where we tackle all the components of pain. But trying to get all these people together in a room talking to each other and working to each other is difficult in its own right, and then there's no reimbursement for teaming up like this. So these things tend to not occur as valuable as they would be. So treatments are replicators, memes, and they're similar to biological replicators of organisms that are selected within an interactive network, an ecosystem, and they compete for selection within an interactive network. The healthcare marketplace, and selection is only indirectly related to utility. When I was at Baylor, I called around trying to find how to fund the ketamine therapy, and I called the Orphan Drug Administration, and I finally talked to somebody at the Center for Medicare and Medicaid Services, and they told me that there is no organization in the government that is charged with promoting treatments simply because they would be helpful for people. That everything that comes into use in medicine has a profit motive that is necessary really to transcend the red tape and the financial obstacles to making it become available. Changes in funding are labor intensive. The pharmaceutical companies have people that will call up and hound the agencies to make the drugs available, but nobody's calling for ketamine. That's why it's not going to be available. That's why grassroots effort to promote ketamine is so important. I think if it's going to get out there and become widely available, it's going to come from people that are getting benefit from it. The CPT code for narcosuggestion doesn't really reimburse for the cost of providing it. And so there are several factors that affect replicator vigor. The cost of the treatment, the quality control, how easy is it to control quality. This is an issue with psychotherapy. We all know psychotherapy is helpful, but we can't control the quality of it. So that unlike Prozac, that you can be reasonably sure you've got some Prozac in the capsule when you pay for it, when you pay for psychotherapy, you could be paying for good psychotherapy or something that actually makes things worse, primal screen therapy or something like that. This all comes out of there's a literature on diffusion of innovation that began largely in the agricultural colleges where people were having to disseminate new forms of seed corn and so forth. And this a guy named Rogers has a standard textbook on this that is interesting. But needless to say, when you try to introduce boiling water to a Peruvian village to prevent river blindness, you're not going to get them to adopt it if they have a belief that the heat is a demon that gets into the water and can jump into their body. Okay, that even as good as they would benefit from having sterile water, they're not going to adopt it if it's incompatible with their worldview. So we suffer with the unintelligent design of healthcare, just like the unintelligent design of our bodies, where we have many flaws. That the trachea crosses the esophagus and makes us susceptible to aspiration pneumonia, because the healthcare, like our bodies, is a complex adaptive system and has evolved and is suboptimal, and changes are made by satisfying rather than optimizing demands. Okay, so several issues in the dissemination of ketamine. Who will provide it? We're at a kind of a crucial time where if it has to be provided by anesthesiologists because of excessive concerns by hospital administrators and legal staff and so forth, it probably will inflate the treatment to the point that it will become less available. On the other hand, I think that I'd like to see both psychiatrists and anesthesiologists be able to provide it. Anesthesiologists at a higher dose and combined with other types of agents. How will it be reimbursed? And how will it be adopted by risk-averse hospital insurance companies who have really very little incentive to cover it? When I was learning about ketamine, and I'm just about done here, I talked with everybody I could find who had any experience with it, and I talked with someone who had done a pain fellowship at the MD Anderson Cancer Institute in Houston. And she said that when she first started doing her pain fellowship, she's a neurologist, that they would quite routinely hang a ketamine drip for people that were getting procedures or that had cancer pain. They had done it as long as anybody remembered. They'd never had any complications with it that anybody could remember. And then one of the nurses complained about the supposed medical legal risk associated with having the nursing staff hang a quote-unquote anesthetic agent on the floor, and they stopped doing it. Okay? And that's what institutions do. It's easier to not provide a useful treatment than to accept the minimal risk that might be involved in doing it. How will ketamine providers be trained? How will diversion or abuse be prevented? Ketamine has an abuse potential roughly comparable to benzodiazepines. And but it's still a considerable risk, but it's not as bad as methamphetamine or heroin or drugs like that. Also, pardon?
Benzo addiction's pretty bad though.
It is, but if ketamine is provided intermittently, not every day, it's probably less. And actually, for some reason, the oral ketamine so far does not seem to have, at least as far as I've seen, abuse potential in terms of what people have been talking about, what I've seen personally. Nitrous oxide, by the way, is something that can cause B12 deficiency. It binds to B12, and I had a patient actually become unable to walk with it. So if it does become available as a treatment for depression, there would be a risk for that. So, here are some things that we could provide in a psychoanesthesiology clinic where we'd have psychiatrists and anesthesiologists working together. But a truly, a much better approach to chronic pain. We prescribe a lot of the Suboxone, the partial opiate agonist, that's very helpful for many patients with chronic pain. Anesthesiologists do nerve blocks that are vital very often. Psychotherapy, there are forms of psychotherapy to deal with chronic pain issues. I mentioned the sevoflurane therapy that I worked with early on. That would be something that would be very useful to have available. Facilitated psychotherapy for anxiety disorders. I think not only PTSD, but I thought that this would be useful for obsessive compulsive disorder. Many patients with OCD have such severe anxiety that they can't begin to think about doing an exposure. But you can lower the anxiety with something like propofol and begin them on exposure and get them to get some success with it. But, my experience with propofol makes it clear that exposure therapy does not have to be painful. That you can have like painless dentistry, you can have pain-free psychotherapy too. There's a gentleman named Eugene Lipoff that has published some literature on blocking the stellate ganglion in the neck, which has some of the sympathetic innervation in the body going through for post-traumatic stress disorder that looks very promising. Benzodiazepine detox could be done with a partial benzodiazepine agonist called clonazepam. And there's a pretty good literature, including several articles saying, why aren't we doing this? And again, this would be something that would be very useful because the standard advice for benzodiazepine dependence is that you put patients on a long-acting benzodiazepine and gradually reduce the dose. And actual studies of this show that it works about 25% of the time. Okay? So it fails most of the time. There's a recent study of nitroprusside therapy for hospitalized patients with schizophrenia. It's a nitric oxide donor, showing a reduction in psychosis at a month, and then, as well as acutely. We talked with the director of psychiatry Cottage, and we would dearly love to be able to provide it, but we don't know how to provide this. And nobody, as far as I know, has followed up on this, as they should be doing in the United States to study this. Eventually, I think we'll be able to treat addictions based upon techniques to block the reconsolidation of the addiction areas. There's some promising literature in animals that suggests that this could be a helpful approach. So that's all my slides. They usually use more like 1.5 to 2 milligrams per kilo. And I think that they usually would have an anesthesiologist present here, although sometimes I've worked up to that dose in refractory pain patients because they tolerated it and it seemed to work for their pain. Dr. Krupitsky and Culp have several chapters where they discuss using this. I think I don't feel like I know enough about it to do it confidently with alcoholism, although I do treat patients with alcoholism and substance abuse with ketamine, and it's very often helpful for depression and PTSD and mood disorders and other things that are a backdrop. So I look at that really kind of more as going after the attachment trauma and PTSD. Interestingly enough, there's this literature in substance abuse that talks about attachment. I've got a book called Addiction as an Attachment Disorder, where the idea is that the drug or the alcohol is a surrogate attachment figure that has the advantage when you buy it, take it home, put it on the shelf. It just doesn't work as well as real human relationships.
My contact information, by the way, is my name, Cole Marta, md@gmail.com, COLEMARTA, md@gmail.com. And regarding that, Eli Culp has an institute, and I believe his website's like culpinstitute.com or something like that. If you Google Eli Culp, you can find him. He's still in practice in South Florida, I believe.
And unfortunately, they made ketamine illegal in Russia, so Dr. Krupitsky had to stop that research and was doing something else.
I have a question for him. How about one of your first slides, you mentioned mTOR?
Mhm.
Did no one lectured on that? So I know that it's a mitochondrial cytokine.
Right. Yeah, it's been getting a lot of attention in as far as where it came into my paper was how ketamine is sort of opening doors to alternative entire strategies for combating depression that weren't being considered before, and mTOR being one of these identified molecules, but it wasn't something that was part of our review because it just got so nebulous to look into all of the
I'm just kind of surprised
potential
because it does
mechanisms.
create inflammation, which then turns around and damages the mitochondria more.
Yeah. I'm
Okay.
not sure its role. The mechanisms, basically, like everybody who already has an idea of how things work are trying to implicate their particular models and apply it to ketamine. So I didn't go into much of
Right.
it because it's kind of maddening. It's like the NMDA people are saying NMDA is responsible for it. mTOR researchers are saying mTOR is somehow implicated. BDNF, all kinds of different things.
I mean, I'm not familiar with this either, but I think ketamine has actually anti-inflammatory effects, from what I recall.
Yeah.
I mean, it's not an area of my expertise either.
But yeah, what do you know about it? You
I'm
probably
a
know more
nutritional
than I do about
biochemist,
mTOR.
and I have an interest in mitochondrial research because there's so many toxins in the environment that are damaging and killing mitochondria.
And mTOR has been implicated in
And
being directly toxic to
autistic
mitochondria.
children, I've treated over 2,000 of those in the last 20 years, and they're known to have mitochondrial damage. So it's just kind of part of what I have to pay attention to. Did
Sure.
either of you find have any comparisons with methylfolate for depression?
That's a very interesting area that is really getting even more interesting. I think in 2007, there was an article called The Homocysteine Hypothesis of Depression, written by somebody from Johns Hopkins. And I think the most solid piece of evidence is that there's a gene in the so-called methylation cycle, or an enzyme called, well, you know this, you can say more of that, but called MTHFR, that comes in a couple of alleles that are much less sensitive to folate. And that I had a patient last week that was homozygotic for the C677T and the A1298C.
All four?
Yeah, so he had processing folate about 10% of the normal population rate. And then we've been sometimes getting genetic studies of using 23andMe to look at various genes throughout the methylation pathway, and sometimes particularly when it's combined with MTR and MTRR, it seems to be particularly difficult. But I'm still trying to sort out what is what and how to approach it. I think is still a matter of a lot of debate and discussion, and very little.
There is still a lot,
Yeah.
although there was a book published by William Walsh in 2012. It's a history of 30,000 tests, including those by Carl Pfeiffer, who was a famous psychiatrist, and it talks about all the research they did and how there were different biotypes of schizophrenics and the depressives.
Yeah.
They kind of overlapped as far as the causes were concerned, but in one case they were saying some people didn't have enough folate or methylfolate, others did not have enough methylation. Yeah, I found it, as a scientist, kind of confusing because it wasn't really clear, because none of the 3 generations of people who worked on this, they had all alternative ideas about what it was, and they were measuring histamine levels and so forth. And it got very confusing, but it's a fascinating book. And I do treat schizophrenics and autistic kids and depressives and seizure patients and the hard ones.
Well, I was looking at this literature just recently, and there was an article by E.H. Reynolds, I think it was, from more than 20 years ago, showing that he'd identified a subgroup of patients who had elevated homocysteine levels and reduced folate levels peripherally and in their cerebrospinal fluid, and then they had lower levels of monoamine metabolites in their cerebrospinal fluid. So he was talking about it years ago. Recently there was an article in support of something called Enlight. It's a nutritional supplement that's been supposedly specially formulated to deal with people who have problems with the methylation cycle. And then there's this other interesting literature on cerebral folate deficiency, that there are some people that don't transport folate well
Into the brain, across the
brain.
blood-brain barrier.
Yeah, in the past this was mostly thought to be associated with very severely ill children, but there are some hints that perhaps in a less severe form that may be seen in other normal humans. There was actually a study in autistic children at the University of Arkansas showing that about 75% of children with autism had lower levels of cerebrospinal fluid, folate, and seemed to improve with folinic acid. I think I saw an article that didn't replicate this, so I don't know what the
Well, it depends on whether they're using a methylfolate, which works in the cells, and the folinic acid, which is actually, it's called formal folate as well, works in the mitochondria. The B12 has similar things. It has 2 forms, the active form, because humans, no one really can use vitamins in the food form. They all have to be metabolized to active forms.
I believe the Enlight
That's 3 forms of folate.
Yeah, 3 forms of folate, 3 forms of folate.
Two questions. First of all, have you had any experience with using ketamine to alleviate chronic pain due to neuropathy?
Yes.
First one. And is it effective?
It does seem to be very helpful, yeah. And particularly with complex regional pain syndrome, the ketamine coma therapy, when they put people to sleep with a very high dose of ketamine for 5 to 7 days, are reporting long-standing remission with this, like 8 years in one case with an otherwise untreatable condition. It's virtually impossible to get that here locally. Lower dose ketamine can be very helpful. One of my patients went down and visited with Dr. Kirkpatrick and had been basically curled up in a ball for a year prior to seeing that, and I think it cost her $20,000 or so to do it. But he does 4-day, 8-hour ketamine infusion sessions, and that got her back some functional recovery. And then I can't do the high dose that anesthesiologists do, but I treat her weekly, and she gets, she says it's the most effective treatment she has for pain. And several patients I've treated, even with low-dose ketamine, have reported that if they have a patch of, say, this big on their leg of CRPS or something like that, that it gradually will shrink at a given time. So that I wonder if even a low-dose therapy can be helpful. Sometimes I come have it compounded as a cream and use it along with lidocaine and gabapentin and amitriptyline, and that can be helpful.
Decreasing in the size involved and the intensity is pretty common. Even in people who maybe are being treated for depression and have concomitant pain syndrome, it's pretty common that they're, require less opiates, for example, or less pain management in general.
And the second question is, why is everybody kind of starting as this baseline with the 0.5 milligrams? I mean, you said that you had a personal experience, I think, at 1.5, which seems like that type of experience you had would be very helpful for depression.
Yeah, but not everybody's ready to tug on God's beard right off the bat. Particularly, I think, if patients, I have had, just a few people. I had one patient who had very severe PTSD involving trauma that occurred while she was prone. We treated her in the hospital with IV ketamine, and it's partly related to her being prone on a stretcher, but it produced a severe flashback with freezing at a very, very low dose of ketamine, below 0.5 milligrams. As we gradually, incrementally went up on the dose, the flashbacks became less and less and less, and she didn't have freezing anymore. Now she gets it periodically. Does a reasonable job of helping to control her flashbacks and nightmares. Helps keep it at bay. But most of the time, if you are gentle with people and take your time, I've only seen a few times that it's made flashbacks worse. On the other hand, I've had several patients admitted to the hospital following colonoscopy, triggering a worsening of their PTSD. Which makes sense.
And similar to the use of IV in general, it's sort of an appendage of that this is the first study used, and so in order to be able to compile as much data as cleanly as possible, they've kept the majority of the larger studies have kept the exact same regimen, with no evidence necessarily that is optimal or that other doses wouldn't work or wouldn't be effective. There's some small studies that have been done, but they're not high quality like information that have shown different doses are helpful also. With the alternate routes of administration, it's particularly important to take into account bioavailability. If you put a drug directly into the vein, it's 100% available. Intramuscularly, you have to, typically it's not accounted for, but because it's about 95-97% bioavailabiliability. And it kind of keeps going down from there. Intranasals 45 to 50% bioavailable, orals like 20% bioavailable, hopefully. But yeah.
With the 0.5 kilogram, 0.5 milligram per kilogram protocol, what do patients typically report as it's coming out?
As far as like the subjective effects?
Yeah.
Typically, people, there is an ability, I think, as with most drugs that alter your perception, to fend off to some degree the subjective experiences. So I think it really has to do, this I think ties a lot into the attachment motif, and can even be used kind of as a measure of where you are in establishing a secure attachment with between the therapist and the patient, and sort of how intense of an experience they'll have with a similar dose. Because to some degree, if you're insecure and fearful of what is happening in basically a strange situation, then people will tend to like ground themselves, open their eyes, sort of like grab things, reorient themselves to the non-ketamine sort of world.
Typically, what do people say? What's an example that's typical of what someone is saying?
It's hard to say, I think. I don't know if there is anything that's like a typical experience that people have. People can have like an ego dissolution experience, like Dr. Early described, where people have an experience of a loss of sense of self, dissolving of the ego. Other people have just sort of like a visionary experience. I think setting has a lot to do with that, where they are, their sense of security, as well as the setting, what kind of music is being playing, that kind of.
You said you divided it into three doses.
Two or three doses.
So, like, what's the range or whatever? What frequency of the doses?
Well, I mean,
Why do you do that?
Well, at least certainly for the first session, I'd rather, introduce it gradually to it, so that if you give like a third or a half of the ketamine, then it's just kind of a slightly sedated effect, like, like you've had a couple of martinis or something like that. In the lower dose range, people tell me that usually things seem brighter. Occasionally they have visual hallucinations, but usually not. When you go to the higher dose range, you see near-death experiences, and one patient remember a previous life, all these kind of like visionary type things that are typical of psychedelics.
Transpersonal experience, like becoming objects, becoming spaces, things like that.
Is the therapist commonly interacting with the patient during the ketamine experience or afterwards, as far as how is therapy taking place?
Sure. Typically, it would occur after, or maybe even on a separate day. But there is some word finding difficulty that can be frustrating for people when they're first emerging. So you definitely have to be careful with, not pushing too hard to get in there, but sort of creating a space where people can talk about, if they wish, anything, is pretty important. So yeah, it would be afterward. During, it's sort of a lost cause.
As far as for the suicide patient that you treated, did you need informed consent, or how do you give such a thing to help a patient like that?
I'm sorry for.
For informed consent, do you have to? They should know what they're getting, but how can you?
So we have a
necessarily-
consent form, and we go through, all of the.
Prior, okay, so somebody in great distress,
Yeah.
you're still going to have to try to explain what
Yeah.
what this
Oh,
is,
yeah.
and then have them say, okay, I get it. Like sign things.
Yeah, I'd rather see a patient a couple of times to bond with them before I do a treatment. Rarely I see people that say they're coming in from a distance away that they really want to try to get a treatment from their scene. So, nothing is written in stone. You try to be attentive to what the patient needs, and sometimes I'll do that. But I'd rather have the patient have some degree of security and understanding what's going on. Plus, I'd much rather have them have a good psychotherapist that they're seeing and they're working with to already in place before the first session, so we can kind of coordinate that.
Can you guys talk a little bit about the contraindications? Because you mentioned working with an 89-year-old person, bipolar patients, people kind of at higher risk you might think of. So what are some of the contraindications? I imagine schizophrenia would be one. Are there any, or is it?
So far it has been, and history of psychosis has been a contraindication in the studies that have been done. But recently, actually in the past year, part of the update of our review, there was a study that was done where they gave, I think it was 6 to 8 people involved in the study, and 3 of them had a history of a psychotic episode, or even were having an acute psychotic episode, and they were receiving ketamine on the inpatient psychiatric unit. And I want to say two of the 3, if not all 3, actually had a resolution of their psychotic symptoms and improvement in depression.
Wow. So, are there any
So it's, I would say it's a contraindication. There isn't an established, list, unfortunately. That's one of the downfalls of not having these studies appropriately done. But it's something that I would say ought to be a contraindication, especially in the outpatient setting. If something's acutely psychotic and depressed, they should be in the hospital anyway, for sure.
There's a Japanese study, interestingly enough. In the 80s they did some ketamine challenge studies in schizophrenia, showing that ketamine in low dose would reliably improve or bring out hallucinations and positive symptoms. And there was a discussion about this. But there was a Japanese study where they took patients who had schizophrenia, who presented with something like a broken arm or broken leg, and they compared a group of them that had ketamine anesthesia, a group that had other anesthetic agents not involving ketamine. And surprisingly, they followed them for 2 months, and the group that had ketamine had a lower rate of hospitalization for psychosis. So it's kind of intriguing to make me wonder whether or not, in the short run, it might provoke positive psychotic symptoms, but in the long run, it might even have some positive benefits. I don't know. I've personally treated patients with psychotic mood disorders, and seen that improve.
like current substance abuse issues is obviously something I would consider a contraindication. Out of control, blood pressure, just things not being controlled in general. I like to have any medical issues stabilized.
When you say current chemical dependency issues,
Yeah.
how do you mean that?
Somebody who has a loss of control of use and using substances in the face of consequences. That would be how it would be.
Yet, can you just present data suggesting that it's an indication for exactly that?
Well, it can be helpful, but for example, I had a patient that I was treating who got some benefit from ketamine, but then began overusing intranasal ketamine. And so I ended up having to take him off of that. I think it's an unanswered question. And Dr. Pauly, who's in our clinic, we've been talking about how to approach patients that have substance abuse issues that are getting treated with ketamine safely. And how to monitor them to make sure that they're not using other drugs, and because I think they can potentially benefit from it. But it's an area I don't really feel. I've done it more from the standpoint of treating the mood and anxiety disorders that go along with substance abuse than somebody that was in recovery. If somebody was actively drinking or using other drugs, I would insist on them being in recovery, at least making an attempt at recovery before I would treat them.
And your experience with route of administration, aside from the bioavailability issue, the duration of action variable, does that inform your perspective on intramuscular versus IV administration?
For me, and I think both of us have kind of found that the IM works just as well as the IV. Just in my comparison of having done an IV at Cottage and compared to IM, I think the results roughly seem to be comparable. Now, with oral dosing, I usually tell people, of course, you have to tell people not to drive after taking oral ketamine. I usually give it to them at nighttime as a lozenge, and then that kind of gets past that, but they don't drive until the next day. And then I tell them to lock up the ketamine, keep it in a book safe or something like that, and have sort of some guidelines on if we do home ketamine, how we try to make it safe and monitor it.
Do you feel like that if this does get more popular, that there's a risk of a legal backlash of some sort, especially if there's one or two, adverse cases or something like that, where there could be some kind of negative, backlash or not? Do you feel like it's?
Yeah,
Sure.
absolutely. Yeah.
I think, and this is kind of a dilemma, is that eventually, if this is used in hundreds and thousands of people, somebody will have an MI, or something will happen during a ketamine session. If this happens with a psychiatrist doing it, there's probably going to be a different response than if the same thing happens with an anesthesiologist doing it. In the largest study of ketamine safety, the article by Strayer that looked at 70,000 published cases of ketamine, they found that there was one case of fatality that could be attributed to ketamine, a patient that otherwise had renal failure and a number of other problems. So it seems to be really pretty safe drug, and I have yet to meet an anesthesiologist that's seen someone have a severe adverse reaction to it as a sole anesthetic therapy. In children, sometimes you have to worry about laryngospasm, and I've never seen that or met anybody that has seen that, but particularly if a child comes in the emergency room and they've got a sore throat, and their upper airway is irritated to begin with, I think there's a risk of that.
Is it something like that happened in Russia?
No, I think the problem was that people started abusing it. Russia is a culture where they use crocodile and all kinds of things to alter the pain of living, and just got too widely abused.
What is the APA's position right now?
They're coming up with a position paper, and I can only hope that they don't ruin it, because I can just see that they would come out with a policy that requires 2 hospital lawyers and $5,000 of monitoring and something that would just totally make it a different treatment and make it unavailable for people.
So you mentioned Roland Griffith's work with psilocybin and mystical experience and so forth. And you also mentioned mystical-like experiences with ketamine. So has something been similar been done with ketamine to see what doses reliably can trigger a mystical effect? And studies that looked at whether or not the mystical effect was the curative factor in certain ailments?
To my knowledge, it hasn't been looked at directly, though ketamine's ability to induce the mystical experience, I believe, has been looked at by Ball and Bider. Not totally sure exactly what he came up with.
Yeah, Dr. Krupitsky has some of his work. He talks about, dose range and what type of symptoms you get at different dose ranges. But I don't know that he's talked about. I think there was one article, wasn't there, that Vollenweider's article that suggested that more dissociative effect was associated with more benefit. On the other hand, I have seen people that were not getting a response to a typical lower dose of ketamine that coincidentally had surgery, and I called up and asked the surgeon to give them, in addition to everything else, a good anesthetic dose of ketamine, and they came out of surgery better. So I don't think that you have to be conscious to get antidepressant.
One last question. Just earlier tonight, I was watching YouTube. Someone was talking about using transcranial magnetic stimulation in addition to that, and said it got some remarkable effects. Like some people have been depression-free for up to 3 years. Have you heard anything about that, or are you familiar with that?
The TMS is reported to give a more prolonged benefit than, say, electroconvulsive therapy, where you almost always need to do maintenance therapy. I had one patient that was getting both ketamine and TMS, and there did seem to be some sort of synergistic effect. I don't know any data on that.
Yeah, we didn't include it in our review, but what I have seen, it hasn't been too compelling that it's got significant synergistic effects. Typically, my understanding is that recommendation is to sort of do one or the other, alternate, not effective.
Might there be any benefit for ataxia? There's various forms of ataxia, but do you know what ataxia is? Or
Yeah, spinocerebellar degeneration.
Might ketamine and all help ataxia in any way?
I have no idea. I know that's I have a couple of patients with that, and it's a very difficult thing to treat. I think some of them use a version of coenzyme Q that seems to limit the damage, but there's really not much in terms of treatments available for any
Are
of
you
those
talking
conditions.
about ataxia due to an accident or just
No,
born that way?
Like Machado Joseph's disease, the spinocerebellar ataxia.
Well, I have some children born with ataxia. You sometimes see it in autism. But there are animal models where it's due to a manganese deficiency because that controls the amount of cartilage that's produced.
Huh, that's interesting. Manganese is neurotoxic, and you can get Parkinson's from manganese.
But manganese is necessary to convert glutamate into GABA.
Well, I think that's probably all the time we have. I just had one last question, if I can find it here. Oh, the suicidality. So, showed some impressive findings of depression, suicidality go down, but then there's over a matter of weeks, how many weeks comes back without. So I'm just wondering if there's is there an increase in suicidality that comes with those, because I can imagine it's very distressing to get rid of it for a few weeks and then have it come back. So I'm just wondering if there's an increased.
I would say it goes the other way. I mean, I don't know what you think, but.
Well, first I want to just make sure that it's understood that, that's in studies where they decided to stop that's in the protocol. They've stopped treatment at that point for the purpose of the study and following to see how long the benefits could be extended after stopping. So there have been case reports where people continued ketamine indefinitely, more or less, and varying the frequency based on how they're doing, using best clinical judgment without a return of their symptoms. So hopefully it won't be something that we have to worry about too often if it can be safely done to just continue ketamine at a minimum frequency but effective frequency. Return of depressive symptoms in general, when somebody has had some relief, I would expect would increase people's risk of suicidal ideation at least. But there hasn't been any evidence that I've seen that it's worsened.
I mean, I think, usually what I've seen is it's helpful, because patients may have been depressed for 5 or 10 years, and they suddenly get a glimpse of what the world looks like not being depressed. They realize that it's possible for them,
Yeah.
and
But they're not broken.
It's heartening, there's someone on our email list who's doing ketamine bolus therapy in New York, that he was part of the original study with it, with suicidality. And then, another thing too is that sometimes it can be helpful in sort of clarifying a diagnosis, because depression can look like a lot of other things, and people, when you clear the depression, they look a lot different, and you have a better sense of how the mood affects other aspects of behavior, anxiety, personality, and so forth and so on.
Cognitive functioning. Yeah, there was some concern about possible effects on cognitive functioning because in heavy users, again, you can't dice out heavy user population primarily because, or you can't dice out what ketamine is responsible for, because typically they're polysubstance users, so people who use ketamine. There's very few people who use only ketamine. In that population, there have been a few neurocognitive deficits that have been shown with long-standing heavy use. But in the studies where they looked at that with the treatment for depression, they've shown actually improved neurocognitive functioning. I think they're not sure if that's something that ketamine is causing, or if it's more a release of depression that's caused sort of a return of their baseline higher functioning.
Well, thank you very much. It was wonderful.